Okay, I think we're going to get started. Good afternoon and good evening, everybody. My name is Sarah DeFeo, and I'm the Vice President of Scientific Affairs and Programs here at Ovarian Cancer Research Fund Alliance, and I want to thank you all for joining us today as we continue our webinar series for 2018 with today's presentation that's all about immunotherapy and ovarian cancer. So just a little about our organization. Ovarian Cancer Research Fund Alliance is the largest global organization dedicated to fighting ovarian cancer. We advance research to prevent, treat, and defeat ovarian cancer. We support women and their families before, during, and beyond diagnosis, and we work with all levels of government to ensure ovarian cancer is a priority. Before we get started, just a few housekeeping notes to go through. All of you listeners will be in a listen-only mode throughout the presentation. We should have some time for questions after the presentation, so if you think of a question as you're listening, you can just type it into the Q&A box that you should see on the right-hand side of your screen. I'll select some of the questions and ask our presenter at the end. And for those of you who submitted questions ahead of time when you registered, I do have all of those as well. So I'm going to be looking at those, and we'll make sure that some of those get asked as well. You don't have to wait until the end of the presentation is over to submit your question. You can just type them in as you go along and as you think of them. And because I know some of you will ask, yes, this is being recorded, and this recording and the slides will be available on the OCRFA website starting tomorrow. So if you missed something, don't worry. You can always go back and listen to it again. So, about our presenter this evening, Dr. Dimitri Zamarin. Dr. Zamarin is an assistant attending physician on the Gynecologic Medical Oncology and Immunotherapeutic Services at Memorial Sloan Kettering Cancer Center here in New York City. Dr. Zamarin obtained his MD and PhD degrees from the Mount Sinai School of Medicine, his residency in internal medicine also at Mount Sinai, and his fellowship in hematology oncology at Memorial Sloan Kettering. He is currently a principal investigator on several clinical trials exploring various immunotherapeutic combinations in gynecologic cancers, which means he is the perfect person to give this talk for us tonight. So thank you very much for joining us tonight, Dr. Zamarin, and I am going to pass the mic to you, and you can start your presentation when you're ready.
All right. Let me see. Okay. Can everybody hear me?
We can hear you.
Okay, sounds good. So let me just see if I can share my screen.
If the intro slide is in the way, Dr. Zamarin, click on the Quick Start tab on the left.
Perfect. There we go.
Okay.
Okay, so everybody should be able to see my screen, and these are my slides. You can see them, right?
Yes, I see them.
Okay, sounds good. So I guess I can start. So
yep.
So I'll talk to you guys today about what exactly immuno-oncology means, some of the successes that we had in other cancer types, and in ovarian cancer, and where is the field going. And again, I will leave I think enough time for everybody to have an opportunity to ask some questions. So I'll start by showing you this picture. This is a picture of Edward Jenner. He is considered to be a father of immunotherapy. He was the one that initially vaccinated the boy against smallpox in 1700s, and as you well know, this was one of the most successful immunotherapies we have to date, vaccines against infectious diseases. And in fact, this resulted in elimination of smallpox, or eradication of smallpox rather. And we're striving towards the same goals, obviously, with cancer through the use of vaccines and other types of strategies. So to start with this description of what cancer immunotherapy is, we kind of have to take a look at the picture of what the tumors really are. And if you look at tumors under the microscope, and this is not a microscope picture, this is just a diagram, you can see that there are a lot of cells that compose tumors. There are those ugly-looking pink cells. Those are the cancer cells, and those are the ones that compose most of the tumor mass. But there are other cells that are present within this, this sort of a mix, which we collectively call the tumor microenvironment. And that microenvironment is designed to make tumors grow. So what are some of these other cells? Well, you have the blood vessels that are feeding the tumor, and we do have drugs that are targeting the blood vessels. There are various cells that are lining the blood vessels as well, such as what we call fibroblasts, and those provide kind of overall architecture to the tumor. But you know, for what we're going to talk about today, it's these other cells that are present within the tumor, and those are the various types of immune cells. There are the CTLs, which are the cytotoxic T cells, and those are probably the most important ones that recognize and kill the tumor. But you can see that there are many other cells in there. There's these cells called macrophages, B cells, dendritic cells, and then these myeloid-derived suppressor cells. And as you can imagine, most of these cells do not help with tumor elimination. Those cells tend to be very immunosuppressive. They prevent the immune system from functioning appropriately. And even these T cells, which are the good kind of cells that we'll find within the tumors, they don't work appropriately. And most of the modern immunotherapies that we have actually trying to target these different cell components in order to teach the immune system how to recognize the cancer and expand these good types of T cells. So these are the overall basic components of the immune system. Again, as I mentioned on the previous slide, there are many different cell types that we have, and these can be broadly subdivided into what we call innate immunity as well as adaptive immunity. So innate immunity is composed of cells that rapidly respond to different types of infections. The most common one that you may hear about is a cell called neutrophil. Those are the ones that are circulating everywhere in the peripheral blood. This is our first line of defense against bacterial infections. When we give patients chemotherapy, those are primarily the cells that we monitor. And if somebody has a fever and those cells go down, that means patients need to be admitted to the hospitals and get antibiotics, because those, again, this is our frontline defense against bacteria. Now, on the right side, you see that these other cells, such as B cells and T cells, so these are part of what we call adaptive immunity. It's a slower response, but those are the cells that we can teach to recognize specific things. So again, the innate immunity, in a way, is dumb, and it recognizes everything. It's the first line of defense. But if you want a specific immunity against something, you need B cells and T cells. And whenever we give vaccination against different types of bacteria or viruses, we're really trying to build up a memory against them, and that's through these B cells and the T cells. And then the T cells are more broadly subdivided into the CD4 and the CD8 cells. And the CD8, which is also known as a cytotoxic T lymphocyte, that's the most important one that actually fights cancers and controlling elimination of cancer cells. And there's a variety of molecules that actually control both the cells of this innate and adaptive immunity. They're collectively known as cytokines and chemokines, and some of those can be immunostimulatory, and some of them can be immune suppressive. So overall, we do know that in ovarian cancer, those T cells or CD8 T cells, they're good. So if we take the patients who have newly diagnosed ovarian cancer and we see, does the tumor have T cells within the tumors or does it not, if you look at these graphs, where we look at the overall survival, where we have the survival on the y-axis and the time on the x-axis, we can see that the patients that at diagnosis have presence of intratumoral T cells, those patients do better overall. So that means that the immune system is definitely playing a role in fighting these cancers. So the question is, then, how can we use now this immune system to actually hopefully shrink the tumors? And to answer that, we first need to understand, how does the immune system learn to recognize the tumor as a non-self? Because obviously you do have a lot of these T cells in the body, but they need to distinguish between the tumor cells and the normal cells. So this is basically the overall process of how tumor recognition happened in our body. So, and this cartoon, I think, depicts it very simply, but a lot of times it's difficult to understand, so I'll go over it in great detail. So those are your cancer cells, so the tumor cells. And as they grow, in a normal process of growth, many of these cells die. And as they die, they release all sorts of molecules. And many of these molecules are just proteins that are expressed by the tumor cells. And these proteins can be very abnormal. They're not proteins that are normally seen by our immune system. So these proteins get picked up by this cell type. It's noted here as APC, but it stands for antigen-presenting cell. It's another type of immune cell which processes these proteins. It chops it up into little pieces. Those little pieces are called peptides, and it presents them on the surface. You can see this little red circle in here represents one of these tumor antigens, and it presents these peptides in complex with another molecule called MHC. Now, in our body, we have various types of T cells which are inherently able to recognize these peptides within the complex, within the context of this MHC complex. So when a T cell that has the appropriate receptor comes and recognizes this peptide with the MHC, it is able to become activated. This simple recognition is not enough, so you usually need another costimulatory, we call it costimulatory signal, to fully activate a T cell. And there are another set of molecules that needs to be activated. One of them is called CD28 on the surface of a T cell. But now, once we have these two signals, the T cell becomes activated, it divides, and then it goes back to the tumors, and this is where it's able to kill the tumors. Now, if the process was that simple, obviously none of us would ever develop cancers. So the immune system has various ways to regulate itself, and one of these ways is that these T cells, once they become activated, they express a variety of proteins on their surface, and those proteins act in a negative fashion, meaning they act to shut the T cell down. It is a normal mechanism that our immune system has evolved in order not to develop an autoimmune disease. You cannot be too activated for too long, otherwise patients will develop inflammation and can have what we call autoimmune disease. So these proteins, such as PD-1, CTLA-4, and many others, they control the state of T cell activation. Well, cancers are very smart, and first of all, they have learned how to co-opt these proteins, so they're highly expressed on the T cells which are present within the tumor, not allowing the T cells to function appropriately. But another thing is that the tumor cells have various ways that they use to inhibit these T cells from functioning appropriately. So there are a variety of the cells that are present within the tumors, tumor cells themselves. There are other immune cells called macrophages, Tregs, or regulatory T cells, other types of dendritic cells that inhibit or block the T cells from functioning appropriately. So as you can imagine, there are various immunotherapeutic strategies that we use in clinic try to address these sorts of issues. And we have drugs that are specifically targeting these different components of the tumor immune system, as well as the drugs that are targeting these inhibitory receptors on the surface of T cells. So then, so what are the types of immunotherapies that we have? So again, we're starting with this basic process of how does the immune system recognize the tumors, and again, to summarize, it's the tumors that lyse and release their specific, what we call antigens or proteins that then get presented to the T cell. So one of the oldest types of immunotherapies is vaccines. And what do vaccines do? Well, vaccines basically teach the immune system how to recognize the specific proteins or specific antigens. And I have drawn here many different types of vaccines that there are that have been used for tumors. And those can be very, very different strategies, as you can see here, and they range in complexity. They're collectively called vaccines, but I think I would just urge a word of caution that, you know, one vaccine may be very different from another, and that may, of course, also mean whether the vaccine is more or less effective. So as vaccines, you can actually have whole tumor cells that have been taken out of the patient, modified to express some sort of a immunostimulatory molecule, and those cells get killed so they wouldn't grow back in the patient. And then they get put back into the patient, and in this process, those cells become, again, picked up by these antigen-presenting cells and presented to the T cells. We can have whole proteins. For example, a MAGE-3 protein is one of the types of vaccine that are synthesized and then given to patients. We can give a patient a DNA that's expressing a specific protein, or the proteins can be further broken down into peptides and then given to patients. Some of these tumor proteins can be encoded by viruses or by bacterium. And then, and one of the more complex kind of strategies is when we actually take dendritic cells out of the patients. Those are the antigen-presenting cells. We'll load them with the protein or peptide or anything or any other sort of target for the immune system, and then put them back into the patients with the hope that those dendritic cells now are able to activate the T cells. Now, not every vaccine means that it's something new that we need to give to the patient. And in fact, there is this whole field of vaccination called in situ vaccines. And what that basically means that anything we do to the tumor is actually has a potential to activate the immune system. And we're seeing that more and more now with once we started doing combination clinical trials. So for example, anytime you use radiation or chemotherapy and you kill the actual tumors, that releases these tumor-associated antigens, and those can get picked up by the immune system and again presented to the T cells. This can be true for chemotherapy, radiation, or also some of the targeted therapies that we use. But as you may have heard, at least for the past 15 or 20 years or so, the vaccines by themselves have unfortunately not been found to be necessarily very effective against different cancers. And because, again, there are many different ways that the immune system is controlled. There are many inhibitory checkpoints that prevent those T cells, even once they recognize the antigen, those T cells cannot work appropriately. And as I mentioned on the previous slide, you have all these negative type of regulators on the surface of T cells that prevent their functioning. One of these molecules is called CTLA-4, another molecule is called PD-1, and these molecules, once the T cell becomes activated, they come up on the surface, and again, they prevent the T cell from working appropriately. Well, now we have drugs that actually work against these molecules. So they're, what's drawn in here, this is an antibody, and that's a type of a drug that we use to target either the CTLA-4 molecule on the surface of T cell or a PD-1 molecule on the surface of T cell. And then this PD-1 molecule in turn gets activated normally by this other protein called PD-L1, which is expressed by tumor cells. And we also have drugs that are blocking this PD-L1. And because these are negative regulators of T cell activation, as you can imagine, using these drugs in a way removes the inhibitor. So if you can imagine, if T cell is a car and these are brakes, we're removing the brakes from this car and allowing the T cell now to go and to work appropriately. There are other molecules that are expressed on the surface of T cells that can be positive regulators. So again, if we use the car analogy, this is the gas pedal. So, and there are strategies that are in clinical development now that try to do both, use the drugs that block the brake or remove the brake from the T cell, and that push on the gas pedal or stimulate these other molecules on the surface of T cells. And again, there's still many other cells that prevent the T cells from working appropriately, and we have drugs in development at least that are trying to focus on these mechanisms too. So how well do these drugs perform in clinic? Well, these are some of the initial trials that were done in melanoma. And again, we are now primarily focusing on these class of drugs, what is known as immune checkpoint inhibitors. Those molecules CTLA-4, PD-1, and PD-L1, they're called checkpoints. They check the activation state of the T cell, and blocking them can restore the functionality of T cells. So this is the trial that resulted in approval of a drug called Nivolumab. Another name of it is Opdivo for treatment of metastatic melanoma. This was a phase 3 trial that was randomized against dacarbazine, which is a chemotherapy that we use in melanoma. And this graph in here, I don't know if you're used to seeing the graphs, but it looks like at the overall response rate in these patients. So going down means tumors are shrinking, and each line in here, this is many lines put together. Each line is an individual patient, and it basically demonstrates by what percentage did the patient's tumor shrink. And you can see that there are quite a few patients on the study that had tumor shrinkage by 100%, meaning the tumors completely went away. And then there are other patients that had perhaps not as much of a shrinkage. This line in here, which is set at 30%, is something that we usually use as a cutoff. We basically say in order to call a patient a responder, the tumor must shrink by at least 30%. So in this case, the overall response rate, or ORR, was 40%, meaning 40% of patients had the tumor shrinkage by at least 30%. Now, unfortunately, there's still a number of patients that did not benefit from this drug, and you can see that these tumors actually have increased in size, meaning that the drug was not effective. On the right side, we look at overall survival of these patients. And again, this is compared to the standard chemotherapy. We look at the patients surviving at a specific time after starting the treatment. And you can see with this experimental drug Nivolumab, there are quite a few patients that, at this time point was taken at the year or 1.5 years or 18 months. But now we have longer period of follow-up now, demonstrating that these patients do quite well with these immunotherapies. One interesting thing about these is that you can see that this tail of this curve kind of flattens out, meaning the benefit from this drug, once the patient responds, can last for a very long time. So here is another drug, which is ipilimumab. It's targeting CTLA-4. Its response rate was not as high. It was only in 11% of patients that we saw tumor shrinkage. But nevertheless, this drug was approved for melanoma. It was actually one of the first immunotherapy drugs that was approved. And you can see the patients that received this drug, at least 20% of them had this very, very long disease control and survival. Melanoma patients, unfortunately, usually don't live, before these drugs, they have not lived for longer than a year from diagnosis. You can see that there are quite a few patients that can live for much longer. So it's certainly a great stride that has been made for these patients with these drugs. So here are the names of the commonly used drugs which are immunotherapy. I have I mentioned Nivolumab or Opdivo on a previous slide. It's made by BMS. There's a drug called Pembrolizumab or Keytruda made by Merck. Those are targeting PD-1. There are some molecules that are targeting PD-L1, such as Tecentriq, Imfinzi, Bavencio. Those are probably the drugs you hear on commercials on TV. And there are a couple of drugs that are targeting the CTLA-4 molecule, such as Yervoy and Tremelimumab. Well, how did they perform in ovarian cancer? Well, unfortunately, not as well as what we see in melanoma. This was an initial study that was done in Japan in about 20 patients with metastatic ovarian cancer. You can see that in this case, 4 patients did have tumor shrinkage below 30%, and these 4 patients actually had a pretty prolonged benefit from this therapy. They stayed on study for such a long time, for a pretty long time. Again, this was a very small study, Now, larger studies were performed since that point. This is a study that was recently reported just about a few weeks ago, and this is with a drug called Keytruda or pembrolizumab. This was done in a large number of ovarian cancer patients, 376 patients. They basically looked at two different populations of patients that had only 1 to 3 prior lines of therapy, or cohort B, which is 4 to 6 prior lines of therapy, just to determine whether whether this drug should be used earlier or later. As we know, patients are less likely to respond to chemotherapy when they have had many prior lines of therapy, so they wanted to see whether that's the case for immunotherapy. And this is, again, looking at these sorts of response rates. And again, response rate is not that great. If we look at overall what percentage of patients had the tumor shrinkage by more than 30%, that's what we use as a cut point. So it was only 9% of patients. If you look in melanoma, I said it was 40% of patients. Here we see only 9% of patients that had a reduction of over 30%. There were still quite a few patients that had a tumor reduction by less than 30%. But again, those numbers certainly don't look as good as they do in melanoma. And yes, overall response rate does appear to be 8 to 9%, but we do see that even if you don't get a tumor shrinkage, there are quite a few patients that can still have stable disease. And in this case, it was 37% of patients overall had either disease stabilization or tumor shrinkage. So we can certainly do better. So, well, first of all, can we select the patients that are more likely to respond to these treatments? How can we predict whether a patient has a better or worse kind of a tumor to be used for immunotherapy? So one of the things you may have heard about is, can we look at the actual target expression in the tumors? And again, just to point out here, with these drugs, we're targeting this PD-1 pathway or the PD-L1 pathway. They go well together because PD-L1 binds PD-1. So a question was asked for many cancer types, well, is there a point of targeting PD-1 or PD-L1 if we don't have any PD-L1 in the tumor? Again, it's the PD-L1 protein that mediates the suppression of these T cells. So this was tested in many different cancer types. This is an example in bladder cancer. This is just an example of a cut of a tumor tissue that was stained for PD-L1 expression, and you can see that there is this brown stain showing that PD-L1 can be expressed on both tumor cells, or actually can be expressed on the tumor infiltrating immune cells. And if you look at the patients that have expression of PD-L1 in the tumors, this is an example in bladder cancer, those patients do better as they survive longer on the treatment and are more likely to respond. But that's in bladder cancer. If we look at kidney cancer, that does not appear to be the case. On the left, for example, in here, we're demonstrating that how do the patients do with the drug called Nivolumab, which is a PD-1 inhibitor in patients that do have PD-L1 expression. On the right, it's the patients that don't have PD-L1 expression, and the results are pretty much the same. We don't really see that that benefit that we get in the bladder cancer. So again, it's not uniform. And whenever we get a pathology report that says that this tumor is PD-L1 positive, we'll have to see what kind of a cancer type are we talking about. So, well, what does that mean for ovarian cancer? So again, this is the study that I just showed you before, the 376 patients. And in that study, they were able to quantify, did the patients have high, intermediate, or low PD-L1 expression? So if you look now at this overall response rate, again, you can see if you have a very high PD-L1 expression, it's 16% of patients that had tumor shrinkage. If it's an intermediate expression, 10% of patients, and then if they have no PD-L1 expression, it's only about 4% of them responded. But again, within each of those groups, there were still quite a few patients that had disease stabilization. So overall, this PD-L1 expression does not appear to be a good enough what we call biomarker to select a patient for whether they should respond or not respond to these drugs. I think there are quite a few patients that are PD-L1 negative that can still have a pretty significant disease control, and the patients who are PD-L1 positive do not necessarily have a much better disease control. So we probably cannot just use the PD-L1 as a biomarker. Another marker that we can use that's probably going to be more effective, but we still have to test it in ovarian cancer, is a T-cell infiltration into tumors, meaning if we do see these T-cells within the tumors, you can see this is an example from a melanoma, and I apologize for the pictures, this is before treatment, this is on treatment, we see those T-cells get into the tumor and, and start killing the tumor. And the patients that had higher number of T-cells in their pre-treatment tumors were the ones that are more likely to respond, while the patients that didn't have the T-cells did not respond and their tumors grew. And then on the bottom is an example of a patient that didn't have any T-cells within the tumor, and whether this was pre-treatment or on treatment, the T-cells did not make it there, and unfortunately the tumors grew. So it will be important to see whether that's actually true for ovarian cancer as well. But given the fact that ovarian cancer patients that have T-cells within the tumors in general do better, this is probably going to turn out to be one of the biomarkers we can look at. So what we have from the studies we have done so far is that as a single agent drugs, these immune checkpoint inhibitors such as drugs targeting PD-1 and PD-L1 probably not effective by themselves for ovarian cancer, and we do need combinations. And we always encourage patients to enroll into these combination clinical trials. So there are different drugs that these checkpoint inhibitors can be combined with. The first class of drugs is, again, other molecules, other drugs targeting molecules on the surface of these T cells. So again, this is a T cell. We have a lot of these negative regulators of the immune response. Those again are the brakes, if you will, and there are a lot of activating receptors on the surface of T cells, and those are the gas pedals. And you can pick and choose, which molecules to target. We unfortunately don't know which ones would be the best combinations, but some have already been explored in clinic, and the best data we have so far is with this combination of drugs targeting PD-1 and CTLA-4. So this is an example of, again, a trial in metastatic melanoma of the patients that received either Nivolumab alone, so this is a PD-1 targeting molecule alone, the ipilimumab alone, which is, again, a CTLA-4 targeting molecule alone, or, or the combination of the two. And what you can see from the combination is that there are more, first of all, there are more patients that had their tumor shrinkage. And here, the tumor shrinkage was seen in about 40% with Nivolumab alone. Tumor shrinkage was seen in 60% in the patients with a combination. The ipilimumab, which is the CTLA-4 targeting drug by itself, doesn't have a very good activity, as I mentioned before. So first of all, combination already seems to be better than either drug alone. But more importantly, if we look at how long does it take for these tumors to progress, we can see really now that the combination seems to be better than either of the drugs alone. So that begs the question, is this true also for ovarian cancer? And we have recently completed this study of, again, in a similar way, either comparing the Nivolumab alone, which is the anti-PD-1, to Nivolumab with ipilimumab. The study, as I mentioned, completed accrual, so we should be expecting the results very soon to see whether this is going to be a more viable or a more promising, rather, therapeutic option for ovarian cancer patients. Well, besides combining these immune checkpoint inhibitors with other immune drugs, can we combine them with standard agents, even with chemotherapy, or can we potentially combine it with chemotherapy and just give patients maintenance with immunotherapy? So the answer, at least from other cancer types, appears to be yes. So this is an example of a trial of Keytruda in combination with chemotherapy in patients with lung cancer. And you can see that On the bottom graph is chemotherapy alone. Those are patients with newly diagnosed lung cancer. On the top, we see a combination of chemotherapy with immunotherapy, and there's a significant difference. Those patients do live longer, even from this earlier study that we are seeing. So it certainly makes sense to try to combine chemotherapy with immunotherapy, and it also appears to be safe. Another study asked whether after somebody completes frontline treatment, again, this is lung cancer, so these patients in stage 3 lung cancer get usually chemotherapy with radiation, and then in this case, they were placed on the maintenance drug called Durvalumab, which blocks PD-1. And again, you can see that the patients that received this immunotherapy, they did significantly better than the patients that were just observed. So both of these trials resulted in approval of these drugs for treatment and maintenance in frontline therapy of lung cancer. And similar strategies are being explored currently in patients with ovarian cancer as well. Because there are multiple drugs, there are multiple trials, and they're looking in the different settings in ovarian cancer. So for the patients that are newly diagnosed after they undergo resection, they can go on a trial, this trial called Imagine50, which is carboplatin paclitaxel, the most common chemotherapy we use in ovarian cancer, but it combines it with a drug called bevacizumab or Avastin and another drug called atezolizumab, which is a PD-1 inhibitor, and this is followed by maintenance therapy of either atezolizumab or atezolizumab actually in combination with bevacizumab. There's another trial called Javelin Ovarian 100. It does something very similar using carboplatin paclitaxel in combination with another PD-1 inhibitor called Durvalumab. In recurrent platinum-sensitive disease, there is a similar trial of a platinum-based chemotherapy with Avastin and atezolizumab followed by maintenance. And then finally, in a recurrent or platinum-resistant disease, there are several trials that are ongoing that are combining chemotherapy, and most commonly this is done with a liposomal doxorubicin or Doxil with Avastin and a drug called atezolizumab, or a similar trial of avelumab and liposomal doxorubicin. And there are several other similar trials that are currently ongoing, and we should be hearing about the results actually, hopefully within the next few months to a year. Well, can we combine immune checkpoint blockade with another targeted drug? And the one that has made a lot of headlines in ovarian cancer is a PARP inhibitor. So briefly, what are PARP inhibitors? So PARP inhibitors is probably one of the only targeted drugs that we have that works for ovarian cancers, and primarily working for ovarian cancers that have a deletion of a BRCA gene, a BRCA1 or BRCA2. And how do the PARP inhibitors work? Well, BRCA gene is a gene that's involved in a DNA repair. It's a type of mechanism known as homologous recombination. So when BRCA gene is missing, the DNA repair is mediated by another gene called PARP, or the protein called PARP. So if you can imagine, if in the patients that have that are missing BRCA1 or BRCA2 gene, if we also inhibit this PARP gene, they have no way to repair the DNA in the cancer cells. So now, and when a cancer cell cannot repair its DNA, it dies. So this is, and that's why PARP inhibitors primarily work in the patients that lack this ability to repair the DNA through the BRCA1 pathway and some others. Well, does this, and there are several PARP inhibitors that are currently approved, both for treatment and maintenance. In the patients that completed frontline chemotherapy, there are no PARP inhibitors that are currently approved, but there are some trials that are ongoing with several drugs that I've listed here. In the patients that have achieved a remission after the cancer recurrence, there are several drugs that are available for maintenance called niraparib, olaparib, and rucaparib, and these are all for both BRCA positive and negative patients. And then for patients that have disease, later line disease recurrence, there are at least 2 drugs that are approved right now, which is olaparib and rucaparib. And again, those are primarily approved for patients that either have BRCA mutation in the germline or in the actual tumor. But going back to immunotherapy, can we combine PARP inhibitors with immunotherapy? So this was a recent trial, also presented about 3 weeks ago. This was in patients that had platinum-resistant disease, and what they received is this PD-1 inhibitor, pembrolizumab or Keytruda, in combination with a drug called niraparib. It's one of the PARP inhibitors. And again, they looked for response rate, and this study was somewhat promising. Again, as you may remember, only about 9 to 10% of patients have their tumor shrinkage with pembrolizumab alone. And in this patient population, the PARP inhibitors by themselves also have very poor activity. But by using this combination, the investigators were able to demonstrate that at least, in this case, 25% of patients had the tumor shrinkage by more than 30%, and there were quite a few patients here that actually, achieved tumor shrinkage in addition to them. So this is certainly, it's not a large study, but this early signal certainly does look promising and warrants further investigation. There was a similar study that was completed with a PD-L1 inhibitor, Durvalumab, in combination with olaparib, another PARP inhibitor. This trial also had a second arm that combined Durvalumab with another targeted drug called cediranib. And in both cases, again, those are very small studies. They do see that the majority of the patients do achieve some type of either disease stabilization or shrinkage. And the arrows here indicate that many of these patients continued on therapy for beyond 6 months. Again, those are very small studies. They would need to be reproduced in the larger studies, but these are certainly early signs of activity that these combinations may be working. So in summary, at least what we know from from these kind of drugs that we have used in clinic, and again, this includes tumor vaccines and also these drugs targeting the immune checkpoint, is that we don't think that by themselves they will have sufficient enough activity to be effective in ovarian cancer. And they will likely be more effective if they used in combination. And there are many, obviously, many combinations that can be explored in here. Again, here I'm just giving you examples that we can actually combine now vaccines with these immune checkpoint inhibitors. We can combine chemotherapy, radiation, targeted therapies with the checkpoint inhibitors. And early studies certainly, at least in other cancer types, certainly seem to suggest that these strategies may be effective. Now lastly, I would like to cover another type of immunotherapy for which we don't yet have much data for, but those trials are currently ongoing. And this is a type of immunotherapy known as adoptive T-cell therapies. And again, it is still focused on this T-cell, but the thought is that if we can take the T-cell out of the body and train it to recognize the cancer cells and then put them back into the patients in large amounts, we would be able to achieve a better anti-tumor efficacy. And that has been shown to be effective for some liquid tumors, such as leukemias as well as lymphomas, which resulted in approval of a class of drugs known as CAR T cells. But these strategies are also being explored in various other cancer types, including ovarian cancer. So there are several different types of these adoptive T cell therapies. There's what is known as TIL, or tumor infiltrating lymphocyte therapy, where these T cells are taken out of the patient's tumor, grown out, and then put back into the patient. You can see you grow out these T cells and you put them back into the patients. There are ways to take the T cells out of the patient, genetically modify them to specifically recognize a target on the cancer cells, and then put them back into the patients. And there are ways to take the T cells out of the patient, expand them to specifically, again, recognize some type of target that we know would be expressed on the patient's tumor, and again, put them back into the patient. Again, some of these studies are still ongoing. There are various targets on the surface or even inside of these cancer cells that can be potentially targeted, but it's too early to say whether these are effective against ovarian cancers. Well, and then I cannot do this presentation without mentioning that none of these therapies are without risk, and the potential side effects that one can get from getting an immunotherapy. And these side effects typically result from the inappropriate recognition of normal tissues by these T cells that are activated, and that can lead to the tissue destruction. Most commonly, these are very minor side effects, but in very, very rare cases, these can actually be very significant or even fatal. Early recognition of these side effects and their treatment is very essential, and they do need to be distinguished from other causes, for example, infectious causes or the actual underlying disease. So here are the most common side effects that we see in patients. We can see some asymptomatic abnormalities in the lab work, such as elevation of the liver function test or amylase lipase. Most of these are really inconsequential and just need to be monitoring. In more severe cases, you can get inflammation in the colon, known as colitis. This is very similar to what patients with Crohn's disease or ulcerative colitis would get. You can get inflammation in the liver. You can get inflammation in the lungs. Those are probably the most serious side effects that we see. But again, these T cells can recognize any normal organ. So including some patients get joint pain ranging from just pain called arthralgia to the actual inflammation in the joints called arthritis. Many patients lose their thyroid function and need to be on a thyroid supplementation. And then very rarely we see damage to other organs such as kidneys, muscle, heart. Heart is very, very rare, but it has been reported, and probably you may have seen reports in New York Times last year that some patients have died from this. Again, these cases occur in 1 in every few thousand, but we have to keep in mind that they are possible. The side effects usually very easily reversible. If it's a mild side effect, like for example a rash, topical steroids work very well. Often we have to give systemic steroids to the patient, such as dexamethasone or prednisone, and then when steroids don't work, we use other immunosuppressive medications. Again, the vast majority of the patients, as long as we detect these side effects early, we're able to reverse them without long-term consequences. But there are some patients on occasion that may suffer long-term side effects from these drugs as well. So I'm going to end here, and perhaps now we have time to answer some questions.
Wonderful. That's great. Thank you very much. That was terrific. A ton of great information. So we've got questions coming in, which is great. You can type them into the Q&A box for everybody listening. So let's see. To get started, we have a lot of good questions. So we had several people asked variations of this question. So lots of questions about how immunotherapy approaches are or are not relevant to patients with rarer types of ovarian cancer, for example, low-grade serous clear cell or GCT. Is this being studied, or how are different types of ovarian cancer being studied in, say, these clinical trials?
Sure. It's an excellent question. Well, I mean, I can take those one by one. So clear cell ovarian cancer is usually being explored within the context of all of the other trials as well. Just basically they get lumped with the high-grade serous. And actually, again, these are anecdotal, but it does seem that the clear cell patients do seem to respond maybe more commonly than the high-grade serous patients. Again, these are anecdotal reports because we haven't treated enough patients, but there are trials focusing on these patients, and these patients are usually included in all of the trials with a high-grade serous. Low-grade serous cancers have not been included in these trials because the population, I guess those cancers are more rare. So the only places that we are able to enroll patients with low-grade serous cancer is that if there is a dose escalation study perhaps evaluating this PD-1 agent in combination with something else, the low-grade serous patients in those may be allowed. But I completely agree that these are much more, since the cancers are more rare, and also because the cancers are relatively slower growing, it makes no sense to lump them with the high-grade serous cancers, and designing trials specifically for these patients is appropriate. So, and again, these are primarily done through our cooperative groups, where multiple hospitals focusing on a specific disease can actually enroll a number of patients to those. But I agree, we don't have much data from the low-grade serous cancers yet. GTD is an interesting cancer as well. In the majority of cases, it is. Well, it's not an ovarian cancer, really. It is primarily an endometrial kind of a cancer. And again, most of these patients are cured, but there is evidence that those can be recognized by the immune system as well. These are being explored through the cooperative groups. There's this PARP, the research group called specifically focusing on rare cancers, and they're trying to develop clinical protocols right now for these patients with rare cancer types, where they would be able to enroll through multiple institutions a large number of patients and be able to assess whether these drugs work for these cancers or not.
Great, thank you. So at what point in the course of treatment do you recommend that people think about, if a patient is interested in immunotherapy, perhaps trying a trial, how do you advise her? At what point in the course of treatment do you recommend people have that conversation with their doctor?
Well, in general, with any type of a clinical trial, I encourage for the patients to have a conversation with the doctors early on. The earlier, the better, for several reasons. One is that if we add these drugs up front, and we know that, again, unfortunately, the majority of the patients with ovarian cancer after upfront chemotherapy will have a relapse. But the question is, if we use these drugs earlier, can we have a potential to increase the number of patients that are cured? And and unless we test it in this sort of an upfront setting and combine it with chemotherapy, we might never know that answer. So if there is a possibility, whatever there is a possibility to potentially increase the percentage of the patients that are cured, or even delay the cancer from recurrence, treatment up front right away may make the most sense. Also, we know that this is the time point where the immune system is the least beat up by all of the chemotherapies that the patients have, so perhaps they will respond better. So again, at every point, I feel like when there is a treatment decision that needs to be made, for example, for starting new treatment or switching a treatment, it is a time to probably see other options, or clinical trial options that are available. And again, often these clinical trial options do not mean that you will not, you get this sort of experimental option instead of the standard option. Very often it is actually your standard option that you would be getting anyway, plus with an experimental drug on top. So it's certainly always worthy to explore it at any time that a treatment decision needs to be made. And to that end, I'd also like to mention that many of these trials will not accept patients that have had more than 2 or 3 prior lines of therapy. And the common misconception in the past has been that I'm going to go on a clinical trial once all of the standard treatments have failed. And we often find that once the patients come to us in this kind of a way, that we no longer have studies available for them, and that's for several reasons. One is because this is the way that the companies like to do the trials, and number 2, these patients tend to be much sicker, and they might not have as much of a reserve. Sometimes these immunotherapy drugs take longer to work than the standard chemotherapy. So occasionally tumor grows before it shrinks, but some patients might not have much room for the tumor to grow. So it's always good to think about these treatments earlier rather than later.
Great, thank you. One person asked, so many trials and combinations. How does a patient prioritize which immunotherapy clinical trial to participate in? So how do you recommend a patient who's interested try to navigate those waters?
Well, I guess I mean, unfortunately, most of the time this comes down to logistics. It's just because there are many trials that are in existence doesn't mean that all of the trials are open everywhere. So number one thing is a location. You know, is there a trial like that open in a location close to where the patient lives? And that most of the time that comes down to be the most restrictive type of factor. Now, even if the trial is ongoing, at the time that the patient is ready to enroll, the trial may be on hold. You know, like they have accrued a certain number of patients, and now they're waiting to see whether there's toxicity or not. So again, just because the trial is open doesn't mean that there are spots. So it's so yes, there are many trials, but it doesn't mean that there are many choices that are present at the same time. It's good that there are many choices, and occasionally I do have 2 or 3 trials that I can offer to a patient, and then we have to prioritize together with the patient to see which trial may be more appropriate for them. Sometimes, again, the simple logistics that if you go on one trial, would that exclude you from participation in a subsequent trial, or maybe sequencing of the trials, maybe better to go the other way, that, like if you have a trial that, for example, would not exclude you from the subsequent treatment, you may choose to do it that way.
Right, okay, thank you. Are there trial opportunities for patients who have already been exposed to immunotherapy drugs to participate in trials?
Yep, absolutely. So I think it's actually a very interesting question, just because, again, we know that, if I showed you the slide and 9% of patients have shrinkage of their tumors, and, other patients do not, this would be a perfect population to test that, can we take again now the same drug or a similar drug and add another drug to it and see whether now we're able to activate the immune system. So, perhaps if you asked me the same question last year, I would say that the trial opportunities were much less. Now the companies are more open to exploring for why some patients do or do not respond, and they do, again, not all trials, but many do allow patients that have had prior PD-1 inhibitors, for example.
Okay. Many questions centered around patients with BRCA mutations, and they're asking if BRCA mutation status has any impact either on the efficacy of immunotherapy, or is it factored into trial criteria?
That's a very interesting question that I don't really have an answer to, but I hope we'll have an answer, very soon. And it makes perfect sense. It's just basically BRCA patients respond better to PARP inhibitors. Will they respond better to immunotherapy as well? And there are some mechanisms by which the immune system recognizes cancer cells that may be enhanced by actually having the BRCA mutation. One of it is that these patients may have more mutations. The other thing is that these patients may just have an overall somehow better recognition of tumor cells. For example, if we look at the BRCA mutated tumors under the microscope, they do have more T cells. We know that the BRCA mutated tumors have better prognosis. So it's a very good question whether these patients would respond or not. So we don't have any specific criteria on most of the trials to say that if you are BRCA mutated, you go on the study or not. But hopefully through analysis of the patients that we have treated so far, we'll be able to understand whether this BRCA status is able to predict whether the patient would respond better or not. But it's an excellent question. I'm hoping that that it will be a better response. At least we'll have another option, perhaps for the BRCA patients. But again, until we have the data, we will not know.
Great. Okay. Good. Thank you. We have some questions coming in about, how to phrase this. So, for example, do all doctors automatically test to see if their cancer cells, say, express PD-1 or PD-L1? Or are there things that people should be asking for? I think people are wondering, how would they know?
Sure. So we don't routinely test for PD-L1 expression. If somebody does a test like Caris, for example, or maybe even Foundation One does it as well, I think they automatically now do the PD-L1 staining. The problem with the PD-L1 test is that there are many different tests, and they are very different from each other. So when one test says PD-L1 positive, the other test may call the same tumor PD-L1 negative. As I showed you, PD-L1 is not always a marker for every cancer type to select for patients that are more or less likely to respond. So it is highly influenced by which part of the tumor one is looking at. So the tumors are very heterogeneous. So if, for example, one has a biopsy and that's taken from the area that's PD-L1 negative, it may be erroneously reported as PD-L1 negative while the patient is indeed PD-L1 positive. So it's, most of the people who work in the field agree that PD-L1 is actually not a very good biomarker. So we usually don't encourage patients to ask the doctors to test for PD-L1. We do advise to test for other markers, such as genomic testing to determine, for example, if they have a BRCA mutation that could make them eligible for a PARP inhibitor. PD-L1 is much more questionable. So, if your doctor does do the test and the tumor comes back PD-L1 positive or PD-L1 negative, you should not be, I would caution again, about getting upset or getting excited with either of the results, just because, at least within the context of ovarian cancer, those results are not yet validated. And as we could see, there are patients who are PD-L1 positive that don't respond at all, and patients who are PD-L1 negative that can respond.
Great. All right, so time flies. We've been an hour already, so I think we'll wrap it up. Just sort of one general question. Are you optimistic about the future of immunotherapy for ovarian cancer? I mean, you presented this data that shows its success, significantly greater success in other diseases, and how do you feel about the future of this?
I am definitely optimistic. Like even when we started with chemotherapy, we started with similar response rates in every cancer type, and then we have built on it, and we have gotten to chemotherapy combinations that work well for most patients, at least in the upfront treatment. And yes, immunotherapy is still early. Whether this is for ovarian cancer, it is also early for every cancer type. But but we do see some early signals of activity. I showed you the activity that I showed you perhaps may not be as impressive. But even in these small percentages of patients, when the drugs work, they can work very well. I have had patients on these treatments that have been on for over 2 years with minimal disease and no side effects. So we're hoping that through finding what the appropriate combinations for everybody, we can extend this to more patients. And again, the beauty about these drugs is that when they work, they can work for a very long time, because the drug is not really what we give to the patient. The drug is already in them. It's their own immune system. And if we find the right way how to activate it or to give it a kick, a lot of times we don't even need to continue giving them the drugs. These patients continue to respond for a very long time. But only through doing the trials and all of the what we call biomarker work to try to understand why certain patients respond or do not, we'll be able to answer these questions.
Right. All right, thank you. So we'll wrap it up. I just wanted to end. We had several people asking, so how do I find a clinical trial? And I think there are different ways to go about it. Do you want to sort of, how do you usually recommend, what do you recommend people do beyond talking to your doctor and asking your doctor? Anything else you'd say?
So there are different there are different sites that can help patients navigate clinical trials depending on the disease type that they have. I mean, the most common information site that many people go to, but it's a bit confusing, is the clinicaltrials.gov. It's probably the most comprehensive site because if you know how to navigate it, you can type in your location, you can type in your cancer site, the type of cancer you have, and it will list all of the trials that are available, and you can search about the trials that are, ongoing or trials that are, that have been completed. Again, the site is a little bit complex, but again, with, but not necessarily too difficult to navigate. There are other places on the web that can be more easy, or at least easier to understand. The Cancer Research Institute has a listing of a lot of clinical trials. Again, they also have a good search tool for the patients with different cancer types that they can look specifically for trials in immunotherapy. I'm actually, I apologize, I'm not sure if OCRFA has anything similar or not, but perhaps you can speak to that, Sarah.
Yes, so we do, in fact,
right.
And yes, clinicaltrials.gov is obviously always a great, very comprehensive resource. We do have on the OCRFA website, which is www.ocrfa.org. If you go there and then look where under clinical trials, under for patients, and then click on clinical trials, we have a link where it says look for a clinical trial. We have a link to our clinical trials navigation service. It pulls from all the information on clinicaltrials.gov, so you're getting that same comprehensive list that Dr. Zamarin just described, but the interface is much more patient-friendly. And there's even a phone number you can call where you can speak to a real live human being who will help you, a clinical trials navigator. So, yes, thank you. I just wanted to know if you had anything else other than how we usually refer people.
No, that's probably, yeah, and that would probably be the best way to go, yeah.
Yep. All right, great. So our time is up. I want to, again, thank Dr. Zamarin for his time today, and I want to thank everybody who called in. Do take a minute to fill out the survey that will appear on your screen at the conclusion of the event. Your feedback is always really helpful to us as we put together future webinars. Our next webinar will be Monday, July 23rd, 6 p.m. Eastern Time. Dr. Doug Levine from NYU, he will give us an update on all the latest ovarian cancer research that was presented at this year's top medical meetings. It'll probably cover some of the stuff that you heard about here tonight, actually. So stay tuned for registration details for that. And again, this webinar has been recorded. It'll be posted on our website tomorrow, so you can go back and listen again. And that's it. Thank you all. You can always find more info about us on ocrfa.org. And have a wonderful evening, everybody. Thank you.